Living lobar lung transplantation was developed in response to the mismatch between supply and demand for those individuals awaiting lung transplantation. This technique was proven itself to be beneficial to a select group of patients who would have either become unsuitable for transplantation or succumbed to the disease while awaiting a cadaver organ. The need for donor safety is accentuated with this technique due to the necessity of placing two donors at risk for each recipient. This experience has shown donor lobectomy to be associated with a relatively low morbidity and no mortality. Appropriate donor selection is vital to success in living lobar lung transplantation. The donor selection process is designed to identify donors with excellent health, adequate pulmonary reserve, and emotional attachment to the recipient, willingness to accept the risk of donation without coercion, and age between 18 and 55, no history of thoracic procedures on the side to be donated, and excellent general health. The lobe must be removed with adequate margins of bronchus, pulmonary artery, and pulmonary vein to allow successful reimplantation in the recipient while allowing closer to these structures in the donor without compromise. There has been no preoperative or long-term mortality in lobar donors. The most common complication was the need for a thoracostomy tube for greater than 14 days post-operatively, either for persistent drainage or air leaks, or the placement of an additional thoracostomy tube. The most significant complication was pulmonary artery thrombosis. Donation of the right lower lobe was associated with an increased risk of preoperative complications. Major complications include pleural effusions necessitating drainage, bronchial stump fistulas, bilobectomies, hemorrhage necessitating red cell transfusion, phrenic nerve injury, atrial fibrillation necessitating electrophysiologic ablation, and bronchial stricture necessitating dilation. Minor complications accounted for the remainder. Actual survival with this procedure is 70%, 54%, and 45% at 1, 3, and 5 years respectively, which is similar to the actual survival reported for double lung cadaver transplantation from the International Society of Heart and Lung Transplantation Registry. Although cadaver transplantation remains preferable, these results have shown that living lobar lung transplantation has been life-saving in a select group of severely ill patients who would have either died or become unsuitable recipients before a cadaver organ became available.
After surgery, the patient will be taken to the ICU for close monitoring. Pulse and blood pressure will be checked every 15 minutes, and an EKG will be done regularly to measure the patient's heart rhythm and rate. To determine heart and lung function, the patient's weight, intake, and output will be monitored. The IV and catheter will be used to deliver medications and fluids, and the catheter can be used for the doctor to determine the pressure in the heart to monitor its function. Patients will also be on a ventilator for the first 24 hours after surgery, usually. This will depend on if the patient is breathing well and receiving the right amount of oxygen. The nasogastric tube or feeding tube and urinary catheter will be in place for a few days up to a week until bowel and urinary functions return to normal. And a chest tube will be in place a few days after surgery to drain all the fluids and blood from around the lungs. Pain and or nausea can be common when waking up from the anesthesia, and there may be pain at your incision site. Usually this is controlled by a patient-controlled pain pump where a prescribed dose of medication can be directly injected into the IV whenever the patient feels they need it. After a few days, discomfort should steadily decrease. During the patient's stay in the hospital, they will be taught the importance and instructions for an incentive spirometer. This simple exercise will help them keep their lungs open and active. Coughing is also very important. It will help to expel any secretions to prevent infection. Coughing will put pressure on the incision site, so it may be helpful for the patient to place a pillow over their chest. Peak flows will also be taught to the patient before they leave the hospital so that they can measure improvement when at home. Doing physical activity is also a useful tool in recovering from surgery. It is important for the patient to move around in bed and change positions to maintain circulation and keep strength up. Walking is also beneficial and should be done as soon as possible after surgery. Family and friends can walk with the patient for support during recovery. Usually patients will be in the hospital for around 2 or 3 weeks. This is different for every patient because every patient's body is different and some will recover faster than others. Because of a patient's body's defense mechanism, a plethora of drugs must be given to the patient after undergoing a transplant. Patients will be placed on anywhere from 8 to 10 drugs right after surgery. Medications for preventing rejections are very important, and patients will be placed on at least 3, which they will stay on for the rest of their life. These drugs are immunosuppressants, and some examples are cyclosporines, tacrolimus, prednisone, and rapamune. Other important drugs include antifungal drugs, antiviral drugs, and diuretics. Initially after the surgery, the patient will be given fluids and food via IV. Once the patient is off the ventilator and the endotracheal tube is removed, they may be able to move on to ice chips and/or drink clear liquids. This should be gradually increased until solid food is tolerable. In the hospital, the patient will be on a low-fat, low-sodium diet. Before the patient is discharged, they will meet with a dietitian who will design a plan based on the patient's weight, blood work, and medications. Vitamin and mineral supplements will be added to the patient's medication list as well. 2 of the most important things after surgery are maintaining potassium and sodium levels. Some transplant medications can increase or decrease potassium levels in a patient's body, and to control the levels, it is important that they follow the dietitian's guidelines. Some transplant patients have problems with high blood pressure or fluid retention, so low sodium intake is very important. Follow-up care is very important in the health and recovery of a transplant patient. Follow-up visits will be scheduled by the transplant team before the patient leaves the hospital. Chest x-rays and blood work should be done every week for the first 6 weeks, and then at regular intervals. With all the immunosuppressants that patients take for anti-rejection, transplant patients are more susceptible to infection. They should avoid people with communicable diseases and wear a mask to cover their nose and mouth in public and around other people. Patients should also be very aware of the symptoms of rejection. Bronchoscopies will be done at regular intervals for the first year after surgery, but other signs should be recognized. Shortness of breath, fever, flu-like aches, chills, pain, and cough are common symptoms. Patients should take their temperature every morning. If there is an increase, it could be a sign of infection or rejection. Blood pressure should be taken every morning, evening, and night. Increase or decrease in blood pressure could be a side effect of some transplant medications, but could also indicate fluid retention, and the transplant team should be alerted immediately. The patient's weight should be taken every morning at the same time after going to the bathroom to easily detect a significant gain or loss. The patient's weight should be taken every morning at the same time after going to the bathroom to easily detect a significant gain or loss. Patients should also continue pulmonary rehab for 3 months to increase their strength and endurance after discharge from the hospital. A return to work or other non-strenuous activities can be done after 3 to 6 weeks, depending on patient's recovery. This is Teresa. She just got her nose replaced. And this is Jacob. He wants to get his fingernails removed. And here comes Beverly with all her excitement about her new lungs. She just can't help but share her excitement with everybody else.